Good afternoon, everyone, and welcome to the CDPH and CMA virtual Grand Rounds. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session on valley fever in California, understanding coccidioidomycosis. Several infectious diseases have been on the mind of public health officials in California lately. H5N1, otherwise known as avian or bird flu, and coccidioidomycosis, otherwise known as valley fever, of which 97% of cases are diagnosed in California and Arizona. Today, we'll have our usual state epidemiology update. Dr. Pan will be here in a little bit to share more about COVID and avian flu. And we also are so grateful to have Dr. George Thompson and Gail Cooksey here to educate us more on valley fever. So let's get to it. But first, a couple of housekeeping issues. Next slide, please. Here are our speakers' disclosures and our agenda. Next slide, please. These are our objectives today. Next slide, please. And we're going to start with Gail Cooksey. So Gail Sondermeyer-Cooksey is a senior epidemiologist at the California Department of Public Health. Her work focuses on cocci, otherwise known as valley fever, including disease surveillance, outbreak investigation, and public and provider outreach. Thanks so much for being here today, Gail.
Sure thing. Okay. So, hello everybody. As mentioned, I'm Gail Sondermeyer-Cooksey. I'm an epidemiologist at the State Health Department, and I'm going to be presenting today briefly on an update on the epidemiology of coccidioidomycosis or valley fever in California. Next slide. So just a quick disclaimer that what I present doesn't necessarily represent the views of the state of California. Next slide. So to start off very basically, valley fever, also known as coccidioidomycosis, or what I will mostly refer to as cocci, is an endemic fungal infection in California. And it's caused by inhalation of spores of the Coccidioides fungus from outdoor dirt and dust. It's primarily respiratory, but about 1% of infections can disseminate, typically to the bones, joints, skin, or causing a meningitis. And despite some misconceptions that this is a mild illness, it can be quite severe, chronic, or even fatal. Next slide. And I'm going to frame my part of the discussion today around the main points here, with the bottom line being when and why to consider this diagnosis in California. And this is part of why our website at CDPH for valley fever is called couldbevalleyfever.org, because we just want people to have this on their differential, or the public to have it on their minds and think of it. And I'm going to focus on four main points: expansion of the disease in California, increasing rates, potential risk groups, and then dust and dirt exposure. Next slide. And then next slide again. So cocci endemic areas. Cocci is a disease of the Americas, and in the United States, it's primarily in the southwestern states, as you can see on this map, with over 97% of cases from Arizona and California. But it's also endemic in parts of Mexico and Central and South America. And then recently, we have started to see expansion of valley fever. And one of the first big indicators of this was in 2010, there was an endogenous case of valley fever detected in Washington state. And that was, I think, much further north than most people thought the Coccidioides fungus could exist. And there's further expansion predicted. And the map on the left here is showing modeling studies that have been done on climate predictions and valley fever, showing that by 2065, valley fever could be in much of America into middle America. Next slide. And in the state of California, we have about 7,000 to 9,000 new cases reported each year recently. And most of these cases are among residents of Central California. And this map on the right here shows the median annual rates from 2000 to 2018. And this was a regional analysis that we did of valley fever. And you can see in kind of that pink red color, this is the southern San Joaquin Valley where valley fever gets its name. And the rate there is much higher than any other part of California. Although we do see relatively high rates also in the Central Coast in orange, northern San Joaquin Valley in yellow, and then also in Southern California in the blue and the green colors. Next slide. But one thing I want to mention today is that we are observing quite a bit of expansion of valley fever in California. So something that you may not have previously thought was in your backyard or in your patients where you are may be starting to emerge in those areas. So the map on the left is 2001, where you can really see Central California has those dark blue colors indicating higher rates. But as of more recent data in 2022, much of California is now starting to creep up into these higher rates of valley fever. And in particular, we're seeing increases in the Central Coast into the northern San Joaquin Valley and potentially as far as parts of the Bay Area and the southern Sacramento Valley, and also large increases in Southern California. Next slide. So next, moving on from expansion to increasing rates. So we do see regular peaks and dips in valley fever, and this just shows the number of cases in the state of California over time. Next slide. And the reason for these peaks and dips and for increases are not necessarily well understood, but some of the main factors that we have thought about are climate and environmental factors, since this is an environmental pathogen that lives in the soil. Soil disturbing activities could lead to increases, the movement of susceptible populations, and potentially just increased recognition and reporting could impact trends. Next slide. But one thing that we've noticed over time is that we do see these large surges in valley fever following droughts in California. So the black line here is the number of cases of valley fever by year and quarter. And then the kind of orange brown areas are California droughts and their severity and how much area they cover. And you can see really clearly where it's circled in blue that we have these peaks in valley fever after droughts occur in the state of California. Next slide. So we had the opportunity to look at this more analytically with some great modeling partners at UC Berkeley. And they used modeling data, surveillance Cocci data with climate and precipitation data, and they did find a significant association showing that when we have multiple years of drought in California, followed by a wet winter, followed by a hot summer, that pattern leads to large increases in valley fever in the following fall. Next slide. And it doesn't just occur in the year after the drought ends, but they found that excess cases occur in the 2 years after a drought ends. Next slide. So we had a quick opportunity to test this after this paper came out and this analysis was done, because in early 2023 in California, we saw a wet winter following drought. Next slide. So based on what we had found, we would have thought that we'd see a large increase in the fall, and that's exactly what we saw. And what you're looking at here, the gray bars are the annual cases, the color bars are the quarterly cases in California, and you can see where that black arrow is that in the fall of 2023, we saw a really big upsurge in valley fever in California. And it's turning out that this is going to be a record year for valley fever in the state with the highest rate we've ever had. Next slide. And provisional data for 2024 is also showing an increase. Even though the first 2 quarters did go down from the fall, that's to be anticipated based on seasonality, but these were the highest first and second quarter for valley fever that we've ever had in the state of California. And we are more so going into the season for valley fever right now in the late summer and fall. So it's definitely a time to watch out for increases right now. Next slide. So now, next slide, moving on to potential risk groups. So first off, residents of these high incidence and emerging areas are one of the main risk groups to watch for. People who are living not only in the Central Valley, but in the areas where valley fever is expanding, where we may not have thought of it being before. but also travelers. And this is one of the reasons for this, is that valley fever has a really low infectious dose, and even just a few spores could lead to infection. So travelers to and through these areas could get infected. And in a recent project, we interviewed over 400 cocci patients and found that 8% had traveled to a higher incidence area than the residents. So it may have been a travel acquired infection. So asking about travel and residents is really important in patients. Next slide. And then we also see differences by demographic groups with valley fever. These are median annual age-adjusted rates, and we see about twice the rate in males than females with valley fever in California. Highest rates are in sort of the working age or the older age groups. Lowest rates are in peds, but I will say that pediatric patients can still have very severe disease. And then in terms of racial ethnic disparities, we do see high rates in Black populations as well as Hispanic. Next slide. And we see the same trends in cocci hospitalizations. This is hospital data, higher rates in males than females, rates increase with age, and about double the rate in African American populations of hospitalizations than white. And again, just to emphasize the fact that this isn't just a mild illness, when we interviewed cocci patients who had been reported, about 1 in 3 reported having been hospitalized for their illness. Next slide. So our last thing that I want to focus on is dust and dirt exposure. And just as a reminder, this fungus lives in the dirt and soil. So when dirt and soil is disturbed, that's going to be the highest risk time for someone to potentially get infected. Next slide. And in interviewing patients, as I had mentioned before, we interviewed over 400. And when we interviewed them, we found that about half remembered a high dust event in the 2 months before they got their symptoms. About 40% remembered dust from construction near their work, home, school, or commute, and 13% remembered being exposed to dust at an outdoor event. Next slide. And not only do we see sort of more like recreational dust exposure, but occupational exposure is a big thing in the world of cocci. And of the 250 patients who were employed that we interviewed, over half reported being exposed to dust specifically at work or reported working outdoors, and about 1 in 3 said they ever dug or disturbed dirt as part of their job. So asking about dust exposure and specifically work activities that you're doing can be very important for cocci. Next slide. And just briefly, we also see this in terms of outbreaks at the health department, where we've investigated a number of outbreaks among outdoor workers, particularly on construction sites, among wild and firefighters, archaeologist groups, and military trainees. And I don't have time to go into this in too much detail, but just want to emphasize that even though we do have recommended prevention measures, prevention is really challenging. So more recently, we're really just trying to emphasize people being aware that it's a risk, knowing the symptoms, and asking their doctor about valley fever if they think they might be infected. Next slide. So again, just the summary slide was the major things that I mentioned. And then I just wanted to provide a last slide that has some QR codes with links. The QR code on the left is up-to-date data on valley fever in California. And on the right are provider resources that we try to keep really up-to-date on our website. So the latest IDSA guidelines, there's a great clinical algorithm that CDC just came up with that walks through testing. So if you need kind of a one-stop shop for up-to-date resources, we really try to keep this carefully curated. And with that, I'm done, and I will pass it over to Dr. Johnson.
Hi there, slow on the uptake today, but now I'm thrilled to just briefly introduce Dr. Thompson so we can get going. George Thompson, the third MD, is a clinical professor or a professor of clinical medicine at the University of California Davis School of Medicine with a joint appointment in the departments of medical microbiology and immunology and internal medicine in the Division of Infectious Diseases. Dr. Thompson specializes in the care of patients with invasive fungal infections and has research interests in fungal diagnostics, clinical trials, novel antifungal agents, and host immunogenetics. He is a member of the mycosis study group planning committee and is chair of the mycosis study group education committee, and has been active in the field of mycology for over 15 years and has published over 250 manuscripts to date. I know both of you are busy, so thank you for being here today, and tell us what you know.
Great. Well, thanks so much for the invitation. It's really my pleasure to be here to give really a kind of a broad view of valley fever. Next slide. And here's my disclosures. None of these are particularly pertinent to the talk today. Almost all medical treatment for cocci is off-label. Next slide. And so some of these I'm going to really emphasize questions that patients routinely ask us, and then some things I think are just noteworthy and of interest to clinicians and providers taking care of these patients. So one of the things we're asked not infrequently is where did this fungus come from and why is it only in the Western Hemisphere? And this has been explored in a couple different studies. So one of the things that's really interesting and novel about this particular fungus is it's missing a lot of the enzymes that other fungal pathogens have. So for example, Aspergillus. Aspergillus obviously lives in the environment, eats decaying vegetative material, but Coccidioides, when you compare the genomes of these two different fungi, they don't have those same enzymes that would help it eat vegetative material. They have more chitinases and keratinases to break down hair and nails and those kind of things, which did kind of raise the question, is this carried by a mammalian so-called vector? And we think it probably is. And the two that have been proposed are this Arizona pocket mouse and the kangaroo rat, because the geographic distribution of these two mammalian rodents is very similar to the distribution of Coccidioides in the soil. To add sort of further credit to that hypothesis, we did a study about a decade ago now where we took a bunch of different Coccidioides isolates, did whole genome analysis on those, and with that you can use sort of molecular clocks and backdate most recent common ancestor, and also when did it have expansion of the genomic clades. And if you backdate those different expansions genomically, they correlate with when there was land bridges throughout North and South America. So that leads additional support to this theory that it's carried by these mammalian vectors, and that's really what's responsible for the spread of the disease, and also why it's only in these certain locations. So next slide. And then what about the impact of wildfires? We've seen a big increase in Coccidioides cases over the last few years. Clearly, drought is responsible for both. We see a lot more cases of cocci following periods of drought. We see more wildfires, obviously, during drought. But we started to wonder, is the spread related? Are they interwoven in some aspect? And that really led to founding this field called pyroaerobiology. We wrote this paper in Science in 2020 to really look, is there a living component of wildfire smoke? And it turns out the answer is yes. The fires are actually not hot enough to kill a lot of these different pathogens. And you always hear that even since seventh grade earth science, that fire creates its own weather, and so it sort of entrains air through the surrounding vegetation and soil and then pulls it up into the atmosphere. And we have flown drones over these wildfires. They have live fungi of a number of different sort of who's host pathogens for particularly immunocompromised patients. And we do think Coccidioides may be spread partly as a result of these different wildfires. So remember this, when it's wildfire season, that the air certainly is difficult to breathe, but it also has a living component, both bacterial and fungal pathogens in that soot that's being carried around certainly the country, and can even be carried across oceans, as we saw with the Australian wildfires over the last decade also. Next slide. And so that's kind of all we're going to say about the ecology and environmental issues that come up with Coccidioides species. But as we move into the clinical part of the disease, it's important to really understand the pattern of valley fever progression. And this is pretty old data. This was first published in the 1950s. And if you take 100 patients who are exposed to Coccidioides, they breathe in the spore. Even a single spore is known to be infectious in animal models. But 60% of those patients, or 60 of those, are really not going to have symptoms, or they'll have subclinical symptoms they don't seek out care for. The good part of that is they do have lifelong immunity. They're probably not going to be recognized clinically unless they're in some type of epidemiologic study. The bad part, though, is the 40% that do have symptoms. Some of those have fairly prolonged symptoms in months to even a year or two with uncomplicated disease. The majority of those are going to recover even without treatment and go on to lifelong immunity. But the bottom two areas are what we spend most of our time taking care of in the infectious disease clinic. And that's the 3 to 4 of those patients that recur or relapse. They are going to require long periods of treatment before we give them another chance off therapy. And then, unfortunately, the 2 to 4% that either disseminate or have some other complication from their initial infection. And we'll talk about that in a few slides, what that looks like. The next slide. And so here's routine primary cocci pneumonia or uncomplicated valley fever. The symptoms can be fairly protean. They mimic a lot of other diseases: fever and night sweats, cough, chills, joint pain, pleuritic chest pain, fatigue, which can be quite long lasting. Headache, even with uncomplicated disease, is pretty common. That does not mean they have meningitis. We typically only look for meningitis in these patients if they have a change in their headache, if it's severe, if it's getting worse, or unremitting. Those are the patients we look for meningitis in. And so these symptoms are very similar to bacterial causes of pneumonia, viral causes. A lot of those are very COVID similar. So I think there was a lot of missed cases likely of cocci during the heavy years of COVID-19. But really the hallmarks that can really tip you off that this is valley fever and not a bacterial or viral pathogen are these two at the bottom, these two symptoms in orange. And that's erythema nodosum, or a rash. And you can see that those pictures at right, there's erythema nodosum present on that patient's forearms bilaterally at top, and then over the anterior shins in the picture at bottom. And remember, that's a paniculitis. It's inflammation of fat. So you can feel that as you palpate over their skin. It's painful and typically red overlying the lesion as well. They also have eosinophilia in some of the cases. So if you see a patient with what looks like pneumonia or upper respiratory symptoms and they have an eosinophilia, think about coccidioides as an etiology and consider testing those patients, as it does increase the pretest probability that valley fever is responsible for their symptoms. Next slide. And then these are just some of the more common complications from primary infection. So not all these patients are going to have a lot of CT scans over time, but we do follow their pneumonia to resolution, specifically for these two complications. So their pneumonia sometimes can resolve as a residual pulmonary nodule, and that's cocci inside a granuloma. Cocci is alive in there, but does not need to be treated further. The problem comes up is if they don't know that they had a residual nodule from their infection, and 20 years later they get a CAT scan for different reasons and they find this nodule, there's going to be concern that that might represent lung cancer. So we really go out of our way to educate patients that these are nodules from their cocci. It does not need to be cut out, does not need to be further treated, but we want to avoid a future inappropriate oncologic workup 10 to 20 to 30 years later. The slide on the right shows a small cavity. These also can be difficult to diagnose if you don't know they had recent coccidioides. They're more common in diabetic patients. When they abut the pleura like this lesion, that makes us a little bit more nervous because if they rupture into the pleural space, that's very complicated disease. They often require VAT surgery and certainly antifungal treatment for quite a while. And also practicing in California, we see a lot of tuberculosis as well, so this can be a mimicker. We're not always sure if this is from cocci, is it from TB, is this have a different etiology? So these are patients that we do follow radiologically, and treatment for coccidioides does increase the likelihood that those cavities will close up over time. So that is not a hard indication for treatment, but we do often prefer to treat those patients hoping to close up their small cavities. Next slide. And then some of the feared complications of coccidioidal infection are extrapulmonary disease, and this typically has one of three different manifestations. Cocci likes to go to the skin, it likes to go to the bone, and it likes to go to the central nervous system, either the spine or the brain. It doesn't always coincide with active pulmonary lesions. We think part of the immune response is if they ignore it in their lungs, have an inappropriate response, those are the patients that disseminate. And they may or may not have a coincident pulmonary lesion, but they can prevent with meningitis and not know that they've had recent pulmonary infection with coccidioides. The good news is this is pretty uncommon. It's really about 0.9% of all patients with coccidioides have one of these manifestations. They can, of course, have those at the initial time of evaluation and diagnosis. And when you see these patients with valley fever, this is one of the main things to look for. Do a very careful review of their symptoms. Image things that hurt that are not symmetrical or have an unusual swelling or lesion with that. And then you can see why here at right. And this is an old data set that we've only recently published, but this looked at the natural history of the different forms of coccidioides. So the top, that blue curve with the very low mortality rate, that's uncomplicated pulmonary infection. That red line is dissemination, but not to the central nervous system. So that's dissemination to any other site. And you can see the attributable mortality is increasing substantially. And then that bottom curve with confidence intervals in green is central nervous system infection. So those patients do have a very high associated morbidity and mortality rate. So that's why it's really key to catch these manifestations, image what hurts, lumbar puncture if they have any CNS side effects that seem to be getting worse, and really to consider treatment and seek out expertise if you've not seen those patients in the past. Next slide. So why do some of these patients have such severe disease? There's a real dichotomy for patients who have uncomplicated pulmonary infection, and then we see these other patients who have severe disease. They have meningitis, they have bone lesions, and really why does that happen? Next slide. So we've worked on this problem for a while, and if you could just click in the middle of those gray videos, they should play. And so at left here, which looks like it has a little bit of a lag to it, this is a human neutrophil that we're feeding a Coccidioides endospore. And you can see chemotaxis readily occurs. The neutrophil can sense the presence of that endospore. And then when it's fed to that and given direct contact, the neutrophil readily eats that. It really has no problems ingesting it. Intracellular killing is a different matter. But if you click on the video at right, you can see the problems with even an immature spherule. So this is the in vivo form. Chemotaxis does not occur. The neutrophil could not sense the presence of that immature spherule. And you can see it really has no hope of phagocytosis here. Your neutrophil is not large enough to eat this form of coccidioides. And we think this is a major virulence factor of the organism, is just the sheer size of it alone. A highly coordinated immune response is required. You've got to make a really well-formed granuloma around this. That takes a long time. And we think this is one of the reasons that cocci is such a different pathogen from other fungal pathogens when your immune system is much more effective. The sheer size of this organism gives it an advantage. Next slide. The other aspect that's really changed of recent is the virulence of the organism itself might be changing. And so this is a product really of climate change, or people call it heat and health now is sort of the new buzz term that's been proposed. But it's very clear since 1880, the world is heating up. So it's gone up about 1.5 degrees Celsius, and that's really irrefutable with land measurements. And so most of these fungal pathogens exist in the environment. So they're becoming more accustomed to these temperature changes as well. But the downside of this is we are getting colder, and you can see that here. This is a paper published in eLife a few years ago looking at a number of different cohorts. So true for both men and women, true across different ethnicities as well. We've gotten colder over the last 200 years. So why does that matter? Well, our body temperature is the major defense mechanism for us against fungal pathogens. So as they're getting more adept at warmer temperatures while we're getting colder, there's a concern that that window is narrowing. That coccidioides may be exploiting that. We think other fungal pathogens have already exploited that with Candida auris and the emergence of that, often drug-resistant Candida species, and also sporothrix. And in Brazil, we've seen sporothrix move from a saprophytic environmental pathogen to a zoonotic pathogen. It's now present on cat's claws and really spreading very rapidly throughout Brazil. They're having thousands of cases of sporothrix, even at individual centers, due to the sporothrix outbreak. So this is something to keep an eye on. I think more to come on the adaptation of fungal pathogens to environmental temperature. Next slide. And then what about the host? So that it was mentioned previously in Gail's talk that there's really this very disparate infection rate for men and women. So men get about infection about 6 times more frequently than women. We think that that's biologic rather than sociologic. We can talk more about that in the question and answer period. We know immunosuppressed patients get worse cocci. That's no surprise to anyone. But there has been this genomic ancestry predilection for severe infections. So our patients from Oceania or primarily Filipino oceanic genomic ancestry get much more dissemination than other groups, and then also those of African genomic ancestry. And these genetics at Wright that Amy Sue and colleagues, we were part of this. We've done whole genome sequencing on a large patient group and found polymorphisms within dectin-1, which is how we sense fungi, and then some of the downstream signaling, primarily PCLG2 and then DUOX1, have been seen in these different groups that really predispose why do certain ethnicities have such a predilection for worse coccidioides outcomes and types of disease. So we still need to continue to evaluate this. We've only explained about half of the patients that seem to have nothing wrong with their immune system, no exogenous immune suppression, but have very bad disease, either meningitis or some other extrapulmonary manifestation. Next slide. And then the last part of this is really this male to female ratio. We've been asked about this a lot. Why do males get more disease than females? And for a long time, it was thought this was perhaps sociologic. These different occupations, different hobbies, maybe different amounts of dirt exposure. In this figure at left, we looked at UC Davis at all of our patients that have coccidioides and then by their sex. And so you can see that those differences really are not apparent until about puberty. That still may not get at biologic underpinnings, and certainly may be differences in occupation or career, or exposure, et cetera. And then the risk is maintained really till pretty late in life, into the 80s, before those curves come back together. Well, to look at this, since it's difficult to look at the immunology and sort of the hormonal influences, is we looked at basically a primate colony, saw the exact same thing. The male primates had much more cocci compared to females, but there still could be some behavioral differences. The male primates dig more often than the females. So to get at that, we also found in our UC Davis Veterinary School, we looked at the male dogs and female dogs. But once the dogs were castrated, their risk of coccidioides acquisition returned to the same risk as females. So we do think this is biologic. It's been seen now in 3 different species that male mammals acquire cocci at a much greater rate than females. And that's probably an immunologic difference, which we do think really puts this forward as a biologic phenomenon rather than sociologic. And next slide. And so we're going to talk just a little bit about diagnostic. There's lots of different choices. Next slide. And so the gold standard really remains culture. That's dangerous for your lab. So if you see a report or you're sending cultures from a patient you think has coccidioides, just let the lab know so they can protect themselves. It's a BSL-3 pathogen. Histopathology is fairly characteristic. There's a few mimickers that are pretty uncommon. So certainly in California, Arizona, the histopathology is going to be very characteristic of coccidioides. But then the majority of our patients are diagnosed serologically with antibody testing. So immunodiffusion, complement fixation, those remain the gold standard tests. So EIA testing, the second bullet point there under serology, that's a good screening test. They do need to be confirmed with the more specific test of immunodiffusion and complement fixation. So that's in the new CDC algorithm that's been put forth. There's also a lateral flow assay that's been developed. Its sensitivity is fairly low at 31% is what's been reported by the group in Arizona. Specificity fairly high, so it can be used for stewardship. So what I mean by that is if you have a positive lateral flow assay that's suggestive of acute cocci, you can probably pull them off antibacterials and just treat them with antifungals. So we think that's the primary use of that test. The other part of this that's very useful, complement fixation titers can be followed over time. Those correlate very clearly with patient symptoms and improvement. So it is useful to monitor the complement fixation levels during longitudinal care. Next slide. And then the last part of this that goes with diagnostics that is a bit worrisome is no one had really ever looked at wide-scale susceptibility testing for coccidioides until we published this back in 2017. Fluconazole is given to the vast majority of patients, but this shows at least in vitro, fluconazole is probably the least effective antifungal. We tend to prefer itraconazole or one of the other azoles over fluconazole when we're able to obtain that. There's of course insurance issues with that. But even in this study also, we found fluconazole MICs were very high in about a third of the isolates, and frankly resistant in vitro in 22 of the isolates. So resistance can occur in coccidioides just like in any other pathogen. We can see resistance. So it might be something to keep in mind if patients are relapsing or really not responding to therapy, that a different agent really may be required. And next slide. And then we'll wrap up here with treatment, and then I think Gail and I are happy to take questions for the remainder of the talk here. So current guidelines are really split. It's an unsettled issue if uncomplicated infection needs to be treated because there's a lack of prospective trials. And that sounds a bit counterintuitive, but at least from the retrospective studies that have been looked at, it's not clear that treatment for uncomplicated disease has really altered the course, that those patients don't seem to get better more quickly. We've seen that with other diseases, certainly mycoplasma. There's some concern about that. And then pertussis, we don't know that actually treating pertussis changes the immunologic course of disease. You just kind of cough and the disease runs its course. We don't know if cocci is any different from that. We do tend to favor treatment for all of these groups. If they're immunosuppressed in any way, we treat them. Diabetes increases the risk of complications and cavities, we treat them. And then cardiovascular disease, they're just going to not tolerate a pulmonary insult very well. Pregnancy has a much higher rate of complications, particularly the second and third trimester. Coccidioides has a cytosolic estrogen receptor, so it increases the growth potential of the organism. So we treat pregnant women. And then remember in the first trimester not to use an azole, it's a teratogen. Patients who have a high rate of complications, so Oceania or African genomic ancestry, we tend to treat them and follow them closely. They do not need to be treated for life. That's a common mistake we see. You should just follow them closely to make sure they're not having complications. And then anybody with this exceptionally severe primary infection. Next slide. So fluconazole is the most commonly used medication for primary infection. Again, I've already mentioned some of the problems with that. Itraconazole we generally prefer. We know it has a little better outcomes for skeletal disease, but all of these other drugs are problematic. So itraconazole is a negative inotrope. You can put patients into heart failure. Posaconazole, very good drug, requires therapeutic drug monitoring. We have seen some of those patients develop hypertension on posaconazole. It's sort of a pseudo hyperaldosterone mechanism. Voriconazole, excellent medication, but lots of drug interactions, also requires therapeutic drug monitoring. Sunburn is a big issue with voriconazole, so hard to use with the amount of sunshine we have in both Arizona and California. Isavuconazole doesn't have as much data, but seems to be a little bit cleaner side effect wise. Amphotericin B only available IV with their current formulations. Obviously, a lot of nephrotoxicity, and then echinocandins should not be used for cocci unless in really desperate circumstances as combination. So that's not something we use almost ever. And next slide. And then the good news for this is we do have a number of antifungals in the pipeline at various stages of development. So there's a number of new azoles. There's some inhaled azoles that might be of interest for valley fever. There's an oral amphotericin B formulation that really might give an oral cidal option for the patients with bad valley fever. There's new echinocandins and then echinocandin-like drugs called triterpenoids that might be of interest in combination for severe cases. And then at right are really the two drugs I think we're very interested in for the salvage setting, and that's fosmanogepix, which is a GWT1 inhibitor that is in phase 2 and 3 trials, and then also alorifem, which is an erotamide inhibitor, which is an oral fungicidal agent also, which is going to start phase 3 trials pretty soon as well. So there's lots of new drugs. I think we're very hopeful for even our patients with the most severe forms of infection. We're going to be able to get them better with some of these new agents. And then next slide, I'll stop here, and I think we're certainly willing and happy to answer any questions, but would invite the interested listener to attend the Cocci study group in April, or the mycosis study group, which is coming up next month in Colorado.
Thank you so much. We have a lot of excellent questions, but first we're going to switch to Dr. Erica Pan, our usual presenter, who's going to tell us a little bit about what's going on in the state. Erica's, there we go. We can see you, Erica, but it looks like maybe there's a lag. Maybe just turn off your camera and it might go a bit smooth.
Thank you. Can you hear me? I don't know if my camera's going to work. It may not. Can you
We
hear
can
me at
hear
least?
you now that your camera's off. So let's just go camera off.
Okay, let's see. Can you hear me now?
Yes.
Can you hear me, Kim?
We can hear you.
Okay. All right. And I will try to go quickly. Apologize to everyone for some technical difficulties. And yeah, really want to just briefly thank Gail Cooksey and Dr. Thompson for excellent presentations. And gosh, I have such vivid. Oh, can you hear me? I'd like to just talk about a few other updates across the state related to respiratory virus updates. Next slide.
Sounds like there's
Okay, I think you can still hear me at least. I'm not sure if the slides are advancing. I don't see them on my side, but oh, here
yeah,
we go.
we can hear
So
you
yeah, an update on
now.
respiratory viruses, a little bit about what's going on with avian flu nationally and here in California as far as preparedness and new mpox concerns. Next slide. Let's go ahead to the next slide. I think most of you know, as we wait for that slide, that we are in the midst of our sort of the end of summer, our summer surge. Sorry, you can hear me? All right, I'll keep trying to talk and then go ahead and interrupt me if it's not working. So as far as respiratory virus season, we are in the middle of kind of our end of summer uptick with COVID-19, and we know in general that we typically see not only COVID-19 but flu and RSV during the fall and winter months. And there have been pretty much every season, every year since we've had COVID during the pandemic as well, a summer COVID uptick. So we're certainly in the middle of that right now. And while COVID still causes a lot of hospitalizations, we've seen those be decreased compared to prior years, and outcomes between hospitalized flu and COVID-19 patients are becoming more similar. Also really interesting to see COVID brought to the during 2022 and 2021. And the COVID-19 and flu death is also decreasing. And actually, if you look at flu and pneumonia deaths, there's been a 13% number of flu and pneumonia deaths. Next slide. So what does the summer uptick mean? Essentially, just pull mine too. You know, we again have been seeing peaks in August in the past and in January. Sometimes some troughs in April, and there may be some seasonal seasonality, but it's early to know about these patterns. A lot of people have questions about the new variant activity plus waning immunity, which are likely contributing to these summer waves. So getting, you know, the vaccine in the fall for most people and having infections during the winter wave, our immunity wanes, and then evolving variants. So We continue to see decoupling as well between the magnitude of COVID-19 wastewater activity and severe outcomes. There's been a lot of media and press about high wastewater levels of COVID-19, and in general, they're continuing to track with our hospitalization and cases, but our hospitalization reporting has changed since May of 2024, and it had no longer been required by NHSN after May 2024. That should resume in November of this year. So we'll have better hospital data again. And again, the proportion of deaths due to COVID-19 is lower now than in the past winter. And now I think I'm caught up to this slide, which just a reminder to people about vaccines being a core prevention strategy, and thinking about all of these big respiratory viruses, so COVID-19 and flu, everybody 6 months of age and older. And then thankfully now we have a new mix of RSV for the highest risk, including pregnant women, and then RSV vaccine for older adults. So these are nice graphics from the CDC, and it will be available in the coming weeks very soon. Flu also will be available very soon in this early fall. And then there are RSV administration seasons that are especially true for California. I'm thinking about maternal RSV vaccine during the months of September through January, and infant RSV through October through March. Next slide. Go ahead and go to the next slide. I'll just talk through this next one too. So again, just really emphasizing, because it's newer to clinicians, and thankfully a new tool in our toolbox, reminding you that ACIP recommends that older adults, 75 years of age and older, should all get a single dose of RSV vaccine. And then those who are 60 to 74 years of age, if they're at increased risk of severe RSV disease, if they have other comorbidities. People who got RSV vaccine last fall are not necessarily recommended to receive another dose, because it does appear to provide protection for at least 2 seasons.
Erica, can you hear me?
And it can be given year round, but of course we again want to try to boost that immunity right before the
Erica,
RSV
the
season,
sound
so
is
late summer, early fall
really
is
bad,
something that
Erica.
is a little confusing and complicated to think about. Maternal and pediatric vaccine, maternal vaccine with Abruzvo, which is a Pfizer product at 32 to, yes, briefly, and now it's gone out again.
Erica, can you hear me? I think that the sound is pretty bad. So what we may do is just have folks.
Yeah, I wonder if we should
look
just
at your
share my slides and then let some Q&A happen. Coxie, and happy to come back hopefully next time with a better tech situation.
Sounds great. Thank you so much for trying, and just referring everyone to the fact that all of Dr. Pan's slides are available to you, and so we will definitely have her back next time and do a better job managing the text. So if we could have you two, Gail and George, come back on, I have a few questions. Thank you very much. So, Gail, we had lots, of course, of great questions during this. And one of the questions for both of you really is when to screen. Is there any role of screening patients, all patients or higher number of patients with respiratory disease? And in fact, someone asked, should we screen everyone in endemic areas at certain times? Or is it really just having a kind of a high threshold for thinking about it?
Gail and I are both looking at each other to say um, I think it depends. I think if you live, so if you look at the map of coccidioides, I mean, if you live at sort of the edges of the endemic region, that's probably not enough pretest probability to test everyone. If you live in ground, in Fresno or Bakersfield, pneumonia, you've got a 1 in 4 chance of it being cocci. I think in those really hyper endemic regions, everybody should be tested that has an appropriate compatible illness to avoid delays. The others, so I practice in Sacramento, we're sort of abutting the Central Valley. We generally treat them for pneumonia, for CAP, et cetera. And if they don't get better, then we treat them or test them for valley fever. So I don't know that it's really a one size fits all. The other groups that we screen are those who either are immunosuppressed or going to be immunosuppressed. So patients who are going to start a TNF alpha inhibitor or other immunosuppression. We're a big kidney transplant center, so we that's part of their preoperative workup. So those are all patients we do assess to see if they've had cocci in the past. Gail,
Great.
anything to add
Yeah, I
to?
think you hit most of it that I was going to say, Dr. Thompson. I think on our website, some of the things we suggest are what you mentioned, where if it's illness that you've tried to treat with, let's say, antibiotics that's not getting better, or prolonged symptoms that last a few weeks, we do see that sometimes valley fever symptoms can last for weeks, months, or even longer. That would increase your suspicion. But also some of the things that I tried to mention in my epi portion today, if someone does dirt disturbing work, if they work outdoors, asking some questions about what they've done in the couple months before, and if there was a lot of dust or dirt exposure, particularly in certain areas, might increase suspicion.
Great. Thank you. And Gail, you alluded to the fact that prevention is very challenging. One of our attendees asked, is there any role for HEPA filters, for N95 masks, anything at all that we can do in the very high prevalence areas?
So there have been some studies done, and we have a whole page on our Valley Fever webpage focused on outdoor workers that has some prevention recommendations that we've had industrial hygienists and our OC health department review. So wearing an N95 is protective if it's worn properly and fitted. So on our website, we talk about having a respirator program and making sure it's properly fit. So things like that, you can, if you're driving, keeping your windows up through a dusty area, turning on the recirculating air, staying indoors if it's very dusty, wetting down soil before disturbing are all things you can try. But having been on some sites where we've had outbreaks, these are just really hard to do reliably. It's hard to wear a mask when it's 100 degrees outside and you're dealing with heat-related illness potentially. It's hard to wet soil reliably when there's not enough water on the site. So I think there are things we can try to reduce risk, but it's very challenging to do reliably too.
Thank you. I know, Dr. Thompson, that we didn't have enough time really to go deeply into the treatment, but we do have a couple of people who would like to hear about treatment specifically for meningitis.
Yeah, sure. So meningitis is sort of a spectrum. We see patients who have kind of early diagnosed meningitis with headache, and they tend to do pretty well. They get put on appropriate medications, are counseled extensively that this is a lifelong disease right now. You have to take this forever. And that group tends to do well. The groups that do poorly are those who never really have controlled disease. They never totally return to their baseline, or they come in, frankly, and are not ever diagnosed with cocci until they're in the ICU and are obtunded. That group tends to do poorly, obviously, just by where they start. But also in that group, they can really fibrose parts of their CNS and even end up with a couple different pockets of spinal fluid that are not contiguous. They don't communicate with each other. So our approach to all meningitis patients is they have MRI of their brain and entire spine to make sure that everything is in communication. If there's any abnormalities radiographically, it also gives us something to objectively follow. They clearly are going to have spinal fluid analysis. I tend to follow their spinal fluid every couple months based on their symptoms. And then once they're asymptomatic, sometimes I'll repeat their CSF after 2 years later to make sure it's totally normal. And those patients do really well. But it is a widely disparate disease as far as outcomes, and I don't think we have that all sorted out from a genomic or immunologic standpoint yet.
Okay. Another question that people had is, does a previous history of cocci make you more or less susceptible in the future?
Yeah, there's only been a handful of cases with truly confirmed second infections with cocci. We know what happens. I mean, if you live in the endemic area, you can certainly breathe it in again. That's no surprise. Generally, infection is thought to give you immunity and prevent later infection. Most of the confirmed second infections have been laboratory acquired, so very high level exposure. But we do know what happens in the community and is probably underdiagnosed, just like their initial infections.
Okay.
One thing I'll add really quickly, if it's okay, is, and Dr. Thompson, please let me know if this is what you see as well, is we've certainly interviewed people as part of outbreaks and in our surveillance who have lived in the highly endemic area for their whole lives and think that because of that, they are immune and they couldn't possibly get it, particularly in older ages. And that's not necessarily what we see in our data, that even living in a high endemic area doesn't necessarily mean that you're immune and you could still get it.
Yeah, some people have made it in their 70s or 80s and never had it before. So it's just, I don't know if that's lucky or unlucky, but to have not gotten it when you're younger. But kids do better with almost all infectious diseases. So, there is an advantage of growing up in the Central Valley and having had cocci when you're a kid, because a lot of those people never had any symptoms. And it does protect them, we think, for the majority of their life. In that same vein, there's a lot of interest in cocci vaccines. And we were just at a meeting last week talking about this. And so we do think there may be a fungal vaccine, maybe only 5 or 6 years away.
That is great news. And you read my mind because that was going to be my next question. So um, then the other question I had was, some folks were asking, is cocci reportable, and who's doing investigations? Is it local health jurisdictions or does it go to the state? And about monitoring and tracking, is that done at the county or the state level?
Yeah, so it's a little bit of both. Primarily, it is a reportable disease. Technically, providers and labs have to report valley fever. Primarily, what we see at this point is that laboratories automatically report positives to their local health department, and they report into the state system. So most of it at this point is automatic through the laboratories. So we think it's quite complete from that sense, but we get very limited data from that source. We just get whatever is on a lab report. So I think anything more advanced than that, we don't have a standardized way of interviewing patients or reviewing medical records. So if doctors are seeing something concerning or have something unusual they want to report, we do encourage you to reach out to your local health department or even us at the state and let us know. And we are exploring ways to do more standardized enhanced surveillance, but it's not established just yet.
Great, thanks. We don't have much time. We have so many more questions, but one final question is, with a really complex and often very chronic disease like this, are there patient support groups that you know of for cocci, so that folks can really figure out the experience of other people and get support?
Yeah, that's a great question. I mean, it can be a really debilitating illness for some patients, and even those with uncomplicated infection often have fatigue that lasts for months or years. The Valley Fever Survivors Network has been a good group for some of my patients. They've really enjoyed that. Rob Purdy runs he helps out with the Kern County Bakersfield group and really directs their center. And he's very vocal that he's also a patient. So he's been a great resource and advocate for the whole field of coccidioides, and can't speak highly enough of him.
Great, really helpful. Well, I'm really grateful for you both to be here talking about this super important topic. That is all the time we have today. And I apologize to everyone for the complex issues that we had with Dr. Pan. We will absolutely have her be back next time. Just as a reminder that you will receive that survey around 5 p.m. today. So if you want CME, make sure you attest to your attendance, and we'll send out your CME certificates within a week. And just remember also that you can access this recording at any time. So feel free to rewatch it, send it to colleagues, etc. Our next session will be on Tuesday, September 10th, where we're very excited to have California's Surgeon General, Dr. Diana Ramos, as our special guest. And until then, have a great day and see you next month.